One of the big issues, and this is a big issue for the ownership group, typically. One of the big issues is that sometimes there's drug theft. It's not because the ownership group has any intention of allowing theft to occur, but human beings are human beings. And sometimes the people that we hire don't have the same goodwill and thought in their head as everyone else. And sometimes it's just the very nature of what we're dealing with that you'll find that people divert medication. They pick up medication and they take it somewhere else. They sell it, they do whatever it has to do. They have to do to make a little bit of extra money. And sometimes people are attracted to the field of healthcare because they can divert medication because medication is expensive. And it's not just a narcotic that they might divert. They might divert medications that are anti-seizure medications. They might even divert insulin because insulin has a high street value. They might be diverting benzodiazepines. There's all kinds of things that get diverted. And sometimes it's inadvertent diversion. The thing is, the federal government, through the violation of the Controlled Substance Act and the Drug Enforcement Agency, which is not limited to just looking at controlled substances, the DEA can look at all kinds of other substances as well. The person diverting is relatively low level. It's not the person that's the ownership group, and it might not even be the management group. But the person diverting, that employee may get away scot-free because the DEA doesn't think that it's worthwhile, but they'll go after the ownership group or the management group. And typically it's the ownership group that they go after. And there's no way to know if that's going on in your facility because you're not there necessarily all the time. The only way to tell is to look at the patient and to look at the medications that the patient has actually received. And that's called therapeutic monitoring or urine toxicology or saliva toxicology. Most facilities don't monitor that because they don't think of diversion that way. They think of diversion as somebody selling medication on the street, and they know that they themselves are not doing any of this, so why would they worry about it? Well, the DEA is holding the ownership and management groups accountable for the actions of the employee, saying you should have known that this was going on. And the only way that you could have known is if you actually measure, if you actually take a look at this. So that's one of the things that CareGuard does, is it helps the ownership and management group have better insight into what's going on in their facility and be able to predict which patient, which group, which employee, which pod of people need better monitoring. There's a lot of issues, and it's not just the opioids. And the other interesting thing is it has to do with STDs. Wherever you see diversion of medication, you usually will see STDs. And I know that sounds bizarre talking about STDs in nursing homes, but the issue is that nursing homes have one of the highest levels of medication theft and diversion in the United States. And more importantly, they also have one of the highest levels of STDs. And STDs are considered a sign of neglect. Department of Justice has started a program where if STDs are identified in a facility, they know there are nefarious things going on. And where there's smoke, there's fire. What's happened is the rate of rise of gonorrhea in older adults, the rise of chlamydia and medication-resistant syphilis is dramatic, and it's essentially in the older population. You would think that this would all be occurring in the younger population, the 20 to 30-year-old. No, the rate of rise is actually in the older population, and it's in this nursing home population. And it's scary because chlamydia is dramatically increased. And if the patient ends up with chlamydia or ends up with syphilis or ends up with gonorrhea, that triggers an alert for the Department of Justice that says, hey, we need to look at this facility because that's really odd. And that's where the rate of rise is. So preemptively, it's important to screen the patient when they come in with urine toxicology as well as urine STD, and then intermittently screen the population. Because you don't know if somebody has had a liaison, and we never normally think of older adults having wild sex orgies or parties, but it doesn't take much. And if there is a spread, it's usually pretty rampant and it happens inadvertently, but it really raises alarm bells. And such to the point the Department of Justice has a specific task force to go after facilities where they notice a pattern. And the only way to preempt that pattern is to have a monitoring system that says, hey, we're actively concerned about this, And if this becomes an issue in our facility, we're going to get ahead of it and we're going to do an investigation and we're going to figure this out, because we don't want to have a third party come in and investigate us. We want to look at our own selves and make sure that we're doing this the right way. At the same time as there's been issues with rising costs, at the same time as we're dealing with issues of decreasing reimbursement, there's been a final rule passed, and it's called the Minimum Staffing Standards for Long-Term Care Facilities. And in essence, what these minimum standards did was it's forcing the amount of payment that CMS is forcing to be paid to the staff to improve the employee compensation. They're looking at this and they're saying, hey, look, we want nearly 80% of a Medicaid equivalent payment to go to worker wages. Well, hold on, that's odd. Because if 80% of a Medicaid equivalent payment for a facility goes to the wages, how are you going to pay for food? How are you going to pay for utilities? How are you going to pay for rent? What about the depreciation and therapy? And what about maintenance? If 80% of the cost is going from a Medicaid level to worker wages, what are you going to do with the rest of the money? So what this does essentially is it says one of two things. Either the majority of the facility should be private pay, and you shouldn't take much Medicaid at all, because 80% of the Medicaid payment equivalent goes to worker wages. So you got to reduce the amount of Medicaid equivalents that you have and go pretty much private pay to increase your revenue so that the 80% equivalent can go to wages, or you got to just get out of business because you can't afford to pay everything else and stay in business. I think that this is going to be a problem, because where is this money going to come from? This is really an unfunded mandate. Unfortunately, it's passed, and there are some temporary hardship exemptions that are being done, but eventually those exemptions are going to run out. So we need to do everything we can to get ahead of this situation. And one of the best things that you can do is increase the retention of patients and improve the outcome and differentiate yourself compared to other facilities. And that's what CareGuard does. CareGuard is designed to help you improve your patients. And I'll kind of go through how that works.